All right, I'll invite up next Dr. Nolan Carrillo-Penn from Mayo, Rochester.
Thank you for the opportunity to present our work. We have no relevant financial disclosures. Mesenteric ischemia still carries a high mortality despite improvements in therapy. Retrograde open mesenteric stenting is a hybrid alternative to both open bypass and endovascular therapy that has several advantages, including direct visualization of the bowel, expeditious revascularization, and is feasible despite highly calcified and complex lesions. The early results have been encouraging, however, follow-up is limited. Our objectives was to assess the perioperative and midterm outcomes of ROMS in the treatment of acute and chronic mesenteric ischemia. This is a single-center retrospective review of all patients undergoing ROMS from 2007 to 2020. Demographics, presentation, anatomic characteristics, and outcomes were reviewed. Patients with acute on chronic, and chronic mesenteric ischemia were included. The endpoints of our study were early and long-term morbidity and mortality, technical success defined as successful stenting of the SMA through a retrograde approach, primary and secondary patency, as well as freedom from reinterventions and clinical recurrence of mesenteric ischemia. For a brief outline of our technique, midline laparotomy is performed and the transverse colon is retracted cephalad. The SMA is identified at the root of the mesentery and dissected. Percutaneous access is obtained, and the system is upsized often to a 7-French sheath. Angiogram is performed, and the lesion is then crossed. The stent is then advanced and deployed with care to flare the stent into the aorta. After completion angiogram, the arteriotomy is closed under balloon control, or endarterectomy and patch are performed if necessary. Of over 500 mesenteric revascularizations, 34 patients underwent ROMS at our institution during our prescribed time frame. 85% presented acutely, with 53% of the cohort presenting with acute mesenteric ischemia. 32% presented with acute on chronic. 15% or 5 patients were treated for chronic mesenteric ischemia with ROMS. Those selected to undergo ROMS with chronic mesenteric ischemia had long lesions requiring endarterectomy, had lack of a suitable clamp site, or were high risk for atheroemboli with conventional stenting. The demographics were typical for patients of this population, with the mean age in our cohort of 71 years of age. Over half were female, and 90% were either current or previous smokers. 4 patients had previous mesenteric revascularizations, with 3 celiac stents and 1 patient with a previous SMA stent presenting with acute mesenteric ischemia due to stent thrombosis. The majority of our patients were treated for chronic atherosclerotic disease with or without in situ thrombosis. The remaining patients had a variety of miscellaneous causes, including dissection, emboli with failed thrombectomy, and 1 patient presenting with non-occlusive mesenteric ischemia with extensive pneumatosis and bowel ischemia after a combined heart and kidney transplant with multiple complications. 53% of our patients presented with an occluded SMA. Technical success, again defined as successful stenting through a retrograde approach, was 91%. The remaining 3 patients, 2 of which underwent antegrade stenting, and 1 had an iliomesenteric bypass. 61% received covered stents, and thrombectomy was utilized in 23%. Patch angioplasty was used in 26%. 53% of patients underwent bowel resection, and 71% had an open abdomen planned second look laparotomy. All of these latter 2 categories were in patients with acute or acute on chronic mesenteric ischemia. The median length of stay was 11 days. Our 30-day mortality was high, all in patients with acute presentations. These were related to ischemic bowel, resultant multi-system organ failure, and 1 patient suffering cardiac arrest secondary to hyperkalemia and sepsis. 3% had myocardial infarction, 26% had prolonged respiratory failure, 15% required dialysis, 15% had an ostomy created, all of which were permanent. There were 5 reinterventions within the first 30 days. 2 required repeat thrombectomy or endarterectomy, 2 had percutaneous stent extensions, and one had a percutaneous endovascular aortic septum fenestration and jejunal branch coiling for pseudoaneurysm. Our median follow-up was 3.7 years. Overall, as previously mentioned, our mortality was high. On Kaplan-Meier analysis, our 1-year survival rate was 50%, and this dropped to 46% at 3 years. The crude primary patency in our study was 73%. On Kaplan-Meier analysis, this was 70% at 1 year and 61% at 3 years. This analysis, however, is highly limited by standard error given the high early mortality. The primary assisted patency was 90%. However, on Kaplan-Meier analysis, this was 87% and preserved at 1 and 3 years. Secondary patency was 97% at 1 and 3 years. 5 patients required reintervention after 30 days. All of these were percutaneous endovascular procedures with angioplasty and stenting, and there were no conversion to bypass. Landmark analysis was performed in patients surviving discharge. 1 year freedom from late reintervention was 87%, and at 3 years, this was 71%. Our freedom from clinical symptom recurrence in patients surviving discharge was 95% at 1 and 3 years, with a single patient presenting with symptoms of chronic mesenteric ischemia after stent occlusion, which was subsequently recanalized. In summary, our data shows that ROMS has a high rate of technical success despite a high number of occlusions and difficult lesions. Acute mesenteric ischemia is still fraught with high early mortality and bowel rates similar to previously described literature. Midterm patency rates are acceptable, and there's a low rate of clinical recurrence. In conclusion, ROMS expands the therapeutic range of treatment to more critically ill patients with expeditious revascularization and direct examination of the bowel, and for this reason is a key technique in the armamentarium of vascular surgeons. Thank you.
This paper is open for discussion.
Hi, Josh Ramberg. So I really love this technique. I mean, I think it's phenomenal in general. If you look at the data, you would think it's the worst thing ever, given the mortality rates. But I think we would all suspect that there's a little bit of patient selection bias here. Have you applied this to the generalized mesenteric chronic ischemia population? I think we saw papers yesterday about how poorly residents have come out, and there was a BKA paper, and residents aren't able to do a lot of procedures on their own, and certainly a mesenteric bypass is a challenging procedure. Can this be applied to more chronic disease, is what I'm trying to get at, as opposed to just this patient population?
Sure. Yes, that's a great question. Can this be applied to chronic patients? Yes. In our cohort, that was only about 15%. And those patients had more difficult lesions, as previously mentioned, or were high risk. So there is certainly a role for ROMS in chronic mesenteric ischemia. It certainly won't supplant percutaneous endovascular procedures with a high rate of technical success and patency rates similar to ROMS for percutaneous stenting. And certainly there are patients who will require bypass, but I do certainly think there is a role.
Dr. Lee.
Wonderful presentation. Your group has previously shown really for antegrade stenting that covered stents should be used basically primarily. So I noticed in this series only 61% of the time you did. Was there any factor that led to bare stents being used for the retrograde, and or did they also have a worse outcome? Did those that sort of occluded early were the ones that were the risk factors for the early mortality?
Sure. In regards to the covered stents versus bare metal stents, obviously some of this cohort was prior to that paper by Dr. Rodrich and Dr. Mendez, and there was a percentage of bare metal stents prior to that. However, there were, naturally in patients with bowel resection, there's always consideration for putting a covered stent in, although we do this fairly routinely, even in contaminated cases, and haven't had a bowel resection and complicated by infected covered stent. But there is something to be said for looking at that. My study with only 34 patients, although this is the second largest on ROMS and has the longest follow-up, is severely underpowered for any type of secondary analysis, really looking at either covered stenting versus bare metal stenting, and as well as the predictors for acute mortality.
Looks like we have another question.
Hey, solid data set. 34, it's still a good number for this sort of procedure. Really great presentation. My question, did you ever think to maybe compare your data set to pre-ROMS mesenteric ischemia? See if how they compare, if one technique might be superior to another.
We haven't looked at that yet, although we have a number of ongoing projects related to mesenteric ischemia, both in our long-term data of chronic mesenteric ischemia and stenting, as well as multiple studies trying to identify predictive factors for patients presenting with acute mesenteric ischemia. That is a great additional topic that we can look into and see whether our mortality rates have changed, although realistically, based on our large series that have been previously published, it's not substantially different.
Nolan, let me ask you one final question.
Sure.
Your rate of cumulative rate of early and then late reintervention is not insignificant. Did you tease out any risk factors for that? And specifically, did you notice a difference between those that were patched versus those that were repaired primarily?
We did look at all of those again with 34 patients and high early mortality. We're underpowered to see any differences really between those cohorts, although it's something that I know Dr. Mendez and I had really hoped we would be able to sneak through, but we're underpowered.
Beautiful presentation. Thank you.
Thank you.